Hello everyone. I would like to give a talk about Kawasaki disease. It's very common among the Asians, and also I'm afraid it's a little bit common than Caucasians in Kazakh. So during my stay in Almaty, I met a patient with Kawasaki disease after the acute coronary syndromes, and he's now taken care of by cardiologist after the SCS. So I would like to review what Kawasaki disease is, and then focus more on the follow-ups by cardiologist, how to follow up the patient with Kawasaki disease with cardiac complications. So this is the overview of the Kawasaki disease that is also called MCLS, mucocutaneous lymph node syndrome. It is mainly used in the US, but yeah, of course the Kawasaki disease is named after Professor Kawasaki. He just passed away about 5 years ago, unfortunately. I met him several times, about 10 years ago and 15 years ago, and he's very gentle scientist, and also he devoted all his life to clarify this disease etiologies and also the development of new therapies. So Dr. Kawasaki is very famous and very well admired doctor in Japan. So in Kawasaki disease, those are the main symptoms we often see in patients with Kawasaki disease. So fever continues more than 5 days, long-lasting fevers. But this is not so specific. We also have several diseases that have very high fevers, long-lasting one more than 5 days. And also hyperemia on bulbar conjunctiva of both eyes. So please take a look at the conjunctiva when you examine the patient, especially the children or infants with high temperatures. Check conjunctiva. And also the mouth lips, that is mucocutaneous phenomenon, findings of the Kawasaki disease. So mouth lips and red strawberry tongue, that is so please take a look into their mouth. And also undefined rash. It's totally different from what we found in the patient with lupus. So the rash is very common, we can find in Kawasaki disease patient. And also the limb edema, it's not soft, hardened edema, and edema of the palm or palmoplantar or finger toe tips. So take a look at their limbs and fingers and hands if it's edematous or not. And also we can find a large cervical lymph node swelling. It's apart from the infection, but recently when we do the ultrasound on the neck, we found a large lymph node swelling after the COVID vaccinations. So sometimes it's very difficult to distinguish the lymph node swelling from secondary lymphadenopathy of COVID vaccination, or it's Kawasaki disease findings. So please ask the history of the vaccinations and check if it's related with the vaccination or not. So the disease prevalence is here. I can show you it's gradually and steadily increasing in Japan, and I think it's all over the world. And we have some incomplete phenotypes, so they lack the very typical findings, but still we can diagnose them as a Kawasaki disease is increasing. Okay, and the yellow one is female and blue one is male, so a little bit male dominant, but also we can find the Kawasaki disease in the female as well. Okay. So I will talk about the therapy later, but aspirin treatment was launched about 1975, and then IVIG treatment and high-dose IVIG treatment started after the 2003 in Japan. So here you can see the mortality is decreased dramatically after the induction of aspirin treatment. Okay, so maybe in Kazakh you may find some patient with Kawasaki diseases. So let's take a look about age of diagnosis and also prevalence of clinical characteristics of Kawasaki disease. So age of diagnosis is predominantly very early age, so from newborn to 3 years old, and gradually decrease after the school age. So this is reported in British Journal of General Practitioners. So it's not necessarily the Japanese Orientals, but also a worldwide phenomenon. So ask the pediatricians not to misdiagnose the Kawasaki disease. And also if the patient is doubtful for Kawasaki disease, please check the coronary arteries. So the number of the Kawasaki disease clinical features, as I listed in the, several slides before, at first presentation, most of the patients shows only one clinical features, or sometimes they are very silent. Okay, so the patient with fully has clinical features very rare in patient with Kawasaki disease. So without doubting Kawasaki disease, we cannot make diagnosis. So there's some seasonal variations of incidence of Kawasaki disease. So it's very commonly happened or diagnosed in the springtime, but it's possibly because of the health checkup systems, and the children's can be seen by doctors during the Easter off or spring vacations, and that easily diagnosed by Kawasaki disease. So all over the year, so any seasons, there is a Kawasaki disease. A little bit less during the summer vacation. Okay. So this is the same slide as I showed you before. Although we have the very good treatment with aspirin or IVIGs, but still there's some fatal conditions. So the Dr. Kawasaki and his groups look for the pathophysiology of Kawasaki disease to find out more effective way of treatment. As you can see here, the mortality rate was first 2.0, very high mortality rate. Now it's almost 0, but still we have some cases of death. So it's very tragedy for the young kids died after the Kawasaki disease. And also the mortality is the cardiovascular events is a big leading cause of the death in Kawasaki disease. So the patients who are resistant to IVIGZ, immunoglobulin therapy, is now we have the scores to predict the IVIGZ treatment resistance. So they are very poor prognoses. So we measure the sodium level, AST, and also the diagnosis day after the onset of the symptom, and neutrophil count, inflammatory markers, and CRP, and platelet number, and ages are very important. So the patient with severe conditions like hyponatremia, the sodium level is lower than 133, and also very high in AST level, and also very high in neutrophil, and CRP is high, and already developed thrombocytopenia, and young are high risks for the IVIGZ treatment. So the patient with severe conditions and the younger ones, we should consider the next steps after the IVIGZ or high dose IVIGZ. And also the early diagnosis is very important. And we have two kinds of scores, but both are very high in specificity or high in sensitivity. So either you can use, but both of them include the ALT, CRP, platelet number, and ages. And this is a little bit lower cutoff points. And also, if the points is exceeded above 3, that is, the patient is more likely to develop the IVIGG immunoglobulin therapies resistance. So today's topic is what is the cardiac complication in Kawasaki diseases. So it's very famous that they have, it's well known that they have the coronary artery aneurysms. So, but aneurysm is only found in 0.64%. So it's gradually decreased year by year. So very first, after the IVIGG therapy, it's dramatically decreased. Also, the coronary artery distension or giant aneurysm is only less than 0.12%. And also we have some valvular changes, aortic valve, mitral valve, pulmonary valve, and tricuspid valve changes. And also in some severe cases we found the coronary artery stenosis, and some develops myocardial infarction. So my case I met in Almaty while I'm staying was very unfortunate case. The MI, the Kawasaki disease proceed to MI is less than 0.1%, very rare, though still we have the patient who have MI in very young age. So as IVIGG resistant can happen, and also even if we use very high dose of immunoglobulins, still we have aneurysms and MIs. So the groups of the Dr. Kawasaki's group look for the pathophysiology of the Kawasaki disease, and not only by them but also worldwidely, pathophysiology of Kawasaki disease is studied. And of course, there is some genetical background because we know that Asians is more high susceptible to Kawasaki disease than Caucasians. So, for example, the morbidity in Japan is 300 cases per year. In Korea, it's about 200, and Chinese Taipei it's about 66. So it's 10 to 20 times higher than Caucasians. So the Eastern Asians are very high risks to develop Kawasaki diseases. And also the GWAS studies showed those candidate genes as the cause of the Kawasaki disease. And some genetical backgrounds is shared with autoimmune diseases such as lupus or rheumatoid arthritis or IBDs. So there's some we know that there's some common pathways that immune responses is a cause of the Kawasaki diseases. And also we already know the poor prognosis markers and also the immunoglobulin therapy resistance as a genes is responsible for those poor prognosis and resistant to the medical therapies. I don't know if you do those genetical tests in Kazakh or not, but in some institute in Japan do the genetical analysis and to look for the risks and specify the treatment. Okay? And also the clinical close watching the review, there's some other etiological agent or pathophysiology of Kawasaki disease. Of course, that is closely related to genetics, but also there is some hypothesis that viral infections such as retrovirus or EB virus or bacteriococcal infection or environmental toxin or antigens are responsible to cause the Kawasaki diseases. But we don't know, we don't have any definite antigens or viruses that cause the Kawasaki diseases. And also recent study about microbiome. As you know, the microbiome is very important to regulate your immune responses and your whole body conditions. Microbiome is the bacterial, the colonized bacteria in the intestines. So dysbiosis, the unbalanced bacteria in the colon or intestines may cause the alteration of the immune responses and lead to the Kawasaki diseases. And also pathological study was done largely in the arteries. This is normal coronary arteries, as you know, and necrotizing arteritis, and also the inflammatory changes are remarkably found in the Kawasaki diseases. But this is not specific. Of course, lots of coronary artery disease patients show the same kind of phenomenon, infiltration of monocyte and also macrophages, accumulation of macrophages. That is a good model to develop the coronary artery stenosis as atherosclerotic changes. And also the role of CD8 T cells and the IgA plasma cells are also involved, is supposed to involve in the Kawasaki diseases. And also the vascular region of Kawasaki diseases, it's acute inflammation of blood vessels, not only the coronary arteries, but it's in whole body blood vessels. But it doesn't last long. It's usually ends on 7 to 8 weeks after the onset of the Kawasaki diseases. But still, the inflammatory cytokines can damage endothelial cells and also vascular smooth muscle cells, and then it will be the cause of the aneurysm formation. So here, the very early stage of the onset of Kawasaki diseases, the TNF-alpha, VEGF, MCP1, those kind of pro-inflammatory cytokines is released or circulating, the increase in the blood level. And then after 10 days, infiltration of inflammatory cells from both inside, I mean that's from the vessels, or from outside, interstitial inflammatory cells migrate into the vasculatures, and also if there is too much inflammation, inelastic plate or smooth muscle cells will be destroyed and cause this arterial stenosis. And after that, an aneurysm formation is completed because of the destruction of those cells and also the supporting cells of the vasculatures. So they are weakened and then cause the aneurysms, especially in the coronary arteries. Okay, and when we measure we check the coronary artery aneurysm by echocardiography, average 5 days, we can see the cardiac artery is highly brightened. So we can measure the brightness, the white color of ultrasound. We can predict the development of cardiac aneurysms, coronary artery aneurysms. So brightness is reflecting the infiltration. Okay, and then after 10 days, the diffusely cardiac artery expands. So it's not aneurysm yet, but distension of the arteries we can detect by ultrasound. And then after 2-3 days, so 11 days, 12 days, there's bump formations, and then it develops the cardiac coronary artery aneurysms. So the ultrasound, the repeatedly examining ultrasound, we can detect the early formation phase of the aneurysms quite easily, non-invasive fashion. Okay. So the pathological findings are this: even if we have the very high inflammation in coronary arteries in acute phase, most of them can regress normally to the normal spontaneously or after the IVIGZ therapy. But some develop the enlargement of small coronary artery or mega lesions. Unfortunately, they develop the mega lesions and then make a clot formations and stenosis of coronary arteries. So in most of the cases we found is not the thrombus but also about intimal hypertrophy to cause stenotic lesions we often found in the coronary artery aneurysm patient in aged cases independent from Kawasaki disease. So in those cases they're easy to develop the ACS. Okay. So where we can find the aneurysms? This is the prevalence of the aneurysms found in Japanese cases. More than 1,000 cases are analyzed, and you can see here in the main trunks are the main lesions to develop aneurysms and also the enlargement. So those are the distal areas are very unlikely to develop the aneurysms. So we just check the main trunks of the coronary arteries by ultrasound, you can detect most of the aneurysms. So about 60 to 70% of the aneurysms found in here, in the right coronary artery and left LCA and LCX are the main trunks of LCA and LCX. So please take a look by ultrasound if they develop aneurysms or not. So this is the summary of the pathogenic mechanism of the Kawasaki diseases. This is a very tentative theory, but environment factors, we don't know what it is, but there must be non-infectious environment factors that regulate epigenomic changes of the immune cells and change the immune responses. So for example, possibly the smoking or some PM 2.5, that's very small particles floating in the air, may interfere with the immune responses. Okay? And also the possibility of the viral infections, retrovirus or EB virus or unknown viruses can cause immune responses. And also there should be genetic factors and also abnormal immune responses, natural immune responses. All together that will lead to the NF-kappa B activation and cytokine storms, and then attack the blood vessels and cause the systematic diseases, and especially in coronary artery diseases. So those infection or NF-kappa B or cytokine storms can be a new target for the Kawasaki diseases, besides the IVIGZ, immunoglobulin therapies. So now there's several clinical trials are undergoing to target those cytokines. And also this is the scheme that you help you understand what is going on in the gut. Okay? So as I told you, this biosis, the bacterial condition in the gut is very important, possibly important in developing Kawasaki diseases. In healthy status, so we have IgA and good microbiomes in the gut, and we have the mucus on the gut, and that is the barriers. But once the patient has the Kawasaki diseases or make an animal model of Kawasaki diseases, and they have the high IL-1 beta, then it will change the microbiome conditions in the gut, and the barriers is loosened, and those cytokines go into the interstitial spaces and promote more immune responses by IgA. And so B cells they differentiate into plasma cells and then cause the systematic inflammations and cardiac complications. That is another new concept of the pathophysiology of Kawasaki diseases. So now we have clinical trials This is one clinical trial. Only a small number of the patient was treated with inhibitor against IL-1 alpha and beta pathways. That the drug is called anakinra. And the number of the patient is only 16. And in this clinical trial, anakinra was well tolerated in the study patient and may have some efficacy in reducing fevers. As you can see here, after the IgG treatment and also methylprednisolone with high dose and is tapered gradually, the patient's CRP level dramatically reduced after the prednisolone, but it recurred several times during the tapering of steroids. And so this anakinra that block the IL-1 alpha and beta was administered, and you can see here CRP levels go down, and also the LAD and LC main trunks LMCA dilatation is reduced by adding the anakinra. So the patient with IVIGG refractory Kawasaki diseases, possibly we can use anakinra to block the IL-1 alpha and beta pathways to prevent cardiac complications of Kawasaki diseases. So maybe there's several drugs are in the pipeline of the clinical researches. You know, the Kawasaki disease is not so high prevalent, so only few number of the patients are involved in the clinical trials. So we have to wait another several years to have new therapeutic ways to treat the Kawasaki diseases and prevent coronary artery diseases. So, and this is the trial that if the methylprednisolone is effective in preventing cardiovascular events in Kawasaki diseases. So the baseline, the blue one, the dark blue one is IV methylprednisolone was done, and the light blue one is a placebo group. And this was published in 10 years ago in New England Journal. And we can see the patient with coronary abnormalities didn't differ before and after the methylprednisolones. Even after we give the longer time, like 5 weeks methylprednisolone treatment, of course the coronary artery lesions decreased, but it didn't change. There's no significant difference between the placebo and the active treatment groups. And patients without coronary abnormalities at baselines, of course, they develop the coronary artery lesions even after the methylprednisolone in very early phase. And after 5 weeks, a little bit decrease, but statistically, we couldn't find any difference between the placebo and the active treatment groups. So the methylprednisolone, of course, it can reduce the inflammatory changes and also CRP decrease as shown in the former slides, and the systematic manifestation can be reduced by the methylprednisolone, but as for the coronary arteries, intravenous methylprednisolone is not promising. So we need new therapeutics. Okay. And here we can see the coronary artery changes in LAD and right coronary arteries, and we can see there is no statistical difference between the placebo and the methylprednisolone treatment group, and also the all patient, and also the no preliminary, the no abnormalities at baselines. We couldn't find any statistical differences. Okay. But also by the methylprednisolone, as I told you, maybe it can prevent some part of the episode of the immunoglobulin D treatment can be reduced a little, but not statistically different. But it can accelerate the discharge time. It was p-value 0.05. So possibly the systematic manifestations can be reduced by methylprednisolone. So the pediatrician who are seeing Kawasaki disease as a primary doctors, they would like to use methylprednisolone, but as a cardiologist, we cannot feel safe if the patient is underwent intravenous methylprednisolone. We have to pay high attention, measuring the ultrasound and coronary artery changes, and also we have to check the ischemic markers from the blood. Okay. So how we should monitor the coronary artery events of Kawasaki diseases? If we found no distension of the coronary arteries, they're not so severe. So class 1 and class 2, class 3, class 4, class 5. Class 5 is the most severe one. It already developed coronary stenosis. And also the class 2 is the transient distension, and 3 is once it has the distension or aneurysms, but on the way of regression, and the 4 is remaining aneurysms. So those patients who has no distension or just transient distensions, we just monitor the EKG and UCG every month, and then 6 months after the onset, and a year after the onset, and 5 years after the onset. We use the ECG and the ultrasound to monitor the coronary artery changes. And no need for CAG or CAT scan or MRI for further investigation of coronary arteries if you don't find any changes in ECG or UCGs. And also ischemia stress tests like treadmill is not indicated for those less severe patients. And patients with regressions, we check the ECG and UCG for every year, and we do the CAG or CAT scan or MRI, whatever you can use. And at the recovery phase in 1 year or at the timing of the regression, we repeat this CAT scan and MRI. And also at age of 18, that is the age of, in our Japanese education system, age of 18 is the end year of the high school. So we check the CAT scan or MRI or CAGs to check the aneurysm formation or the regression or worsening of the aneurysms. If the patient has small aneurysms. If the patient has the medium to large aneurysms, we do the more close watch. So every 6 to 12 months, we may check the ECG and ultrasound for a longer time. And every 3 to 5 years, we sometimes do the ischemia stress tests like treadmills. And also do the CAG every 3 to 5 years. Okay, so if the patient has remaining aneurysm, if it's small every 1 year, but it's medium to large, we do the ultrasound more often and ischemia stress test more often. So in case of the patient has large aneurysms, every 1 to 5 years we do the ischemia stress test, and also do the CAG or CAT scan from 1 to 5 years after the remission. But if patient has coronary stenosis, just as the patient I saw at the Almaty, and he also developed the ischemic changes. So it depends on the symptoms and clinical manifestations. We do the ECG and UCG upon the request, or if we think that it's necessary. So as the ischemic stress test, and also the CAG and CAT scan and MRI. But if patients are symptom-free, we don't do much, at least about the following the coronary stenosis, but no ischemic changes. So every 6 to 12 months, we measure the UCGs, and if they are positive, we do the ischemic stress test and also the CAT scan and MRIs for further investigations. So it totally depends on the symptoms if the patient already developed the ischemic changes. So this is the guideline from the US that if there's no coronary artery lesions in acute phase, just follow up for 5 years. That is recommended by US and also in Japan as well. It's the severity 1 and 2 are not necessary to follow up more than 5 years. But if the aneurysm remains 30 years or later, but no stenosis and aneurysm is regress during the follow-ups, maybe, as I told you, the age of 18 years old, we do the CT, MRI, and if aneurysm is larger than 6 millimeters, follow up for 10 to 20 years. So it's after the school or universities, and even if they are 30 years old, we have to do we are recommended to follow up for a longer time. And if the aneurysm remains after 30 days, but no stenosis and aneurysm no regression during follow-up, check up for every 6 months to 1 year, and repeatedly we follow the aneurysm formation and also the sizes and the thrombus in it or atherosclerotic changes for a longer time than 10 to 20 years. But we have to follow up more than 30 years, 40 years. So it's lifelong follow-ups are required if there remains aneurysms. So it's very essential not to develop aneurysms. So in that case, the methylprednisolone is not effective. So the patient resistant to IVIGs, immunoglobulin therapy, if they are resistant, we look for the new therapies and enroll them into the clinical trials to see if it can reverse the aneurysms. So this is published in any other journals, and this is the recommendation in European and American societies. And the size of the aneurysm is defined larger than 4 millimeters and smaller than 8 millimeters is defined as small to medium size aneurysms. And if it's solitary or multiple, it makes a difference. And also the aneurysm larger than 8 millimeter is you need more close follow-ups. So it depends on the size and also the stenosis occlusion. Existence of stenosis occlusion makes a big difference in the follow-up schedules. So you should remember those stuffs and don't let them go. Just keep the patient for follow-up schedules and let them visit your clinic every 6 months to a year for follow-ups. Okay? So not only the electrocardiography, EKG, but also the ultrasound is very good tools, non-invasive and easy to make a diagnose the aneurysm formations. Okay? So this is especially required for the cardiologist to follow up the Kawasaki disease. So what kind of drugs we should use? Of course, aspirin is very powerful agent to prevent the coronary artery diseases in patients with Kawasaki diseases. So we are very accustomed to use the 80 milligrams or 100 milligrams of aspirin for the adults. But in case of the child, the Kawasaki diseases, the most common onset is from newborn to 3 years old. So in case of children, we modify the dose of aspirin according to the body weight. And also acute phase, we give larger doses of aspirin, and then it reduced to the 3 to 5 milligram per kilo per day. And if they're not tolerant with aspirin, or aspirin is not effective, we can add dipyridamole or triclopidins or clopidogrels in those doses, and they requires 3 times a day regimen, or 2 times or 3 times day of regimen. And if you have the ibuprofen, you can use 1 to 2 milligrams for 3 times a day. We don't use much ibuprofen in Japan. We mainly use aspirin, dipyridamole, and triclopidin, and sometimes clopidogrel in patients with Kawasaki disease together with coronary artery diseases. And in some cases, we use warfarin or unfractionated heparin. And also the same for the adults. We set INR 2.0 to 2.5. Okay? And in case of the heparin, APTT should be the 1.5 to 2.5 higher than the normal, the control, the references. I don't know how do you report APTT in Kazakh, but in Japan we use the APTT, the percent increase of the APTT to the control level. Okay, and the required dose of the unfractionated heparin is 10 to 20 units per kilogram per hour BID in case of the children. Okay, so the warfarin is different from the depends on the ages. So the younger than the year, 1 year old is 0.16 milligrams in average, and after the 1 year old, it's like this, 0.04 to 1.0 milligram per kilo per day. It depends on the genetic backgrounds and also the drug metabolic capacity of the patient. And also, we sometimes use the beta blockers if the patient has ischemic changes. Of course, the beta blockers also started from the lower doses and titrate up to certain doses. So we often use the carvedilol and metoprolol. Especially patient is tachycardic. We sometimes add the beta blockers. And so as calcium channel blockers, nifedipine, amlodipine, or diltiazem. But remember that calcium channel blockers will increase the blood flow. So in patients with very large aneurysms, you have to pay very high attention if you give the calcium channel blockers, because it can accelerate the blood flow and increase the wall stress, okay, in the vasculatures, coronary arteries. So sometimes it is harmful for the formation of aneurysms or extension of aneurysms. So we are very cautious about using the calcium channel blockers. Of course, it can lower the blood pressure and can protect heart, we know. But in case of the patient with coronary artery aneurysms, we pay very high attention. And so is nitrate. Because the patient has ischemic changes, we give nitrates, isosorbide or nitroglycerin for sublingual doses, or isosorbide. We have the ointment of isosorbide, so we use them, and also the per ounce tabs. So QD, the once a day or 2 times a day or sometimes 3 times a day, depends on the formula of the drugs. Okay. Those are the medical treatment of coronary artery involved Kawasaki disease. So I would like to wrap up my lecture on the Kawasaki diseases. And so this is a summary of long-term cardiovascular follow-ups that cardiologists should do. So if the patient is less severe conditions, we give the medications such as aspirin or IVIG only in acute phase. And long-term follow-ups, they are free from the drugs. But at least 5 years, we can follow up them by using the ECG and the EKGs, and no indication for ischemia stress test or CAG or CAT scans. Of course, the PCI or CABG has no indication in those patients. But if they have the small aneurysms or it's a regression, if we can find the regression, or if they are remaining the aneurysms, we do these ECG and UCGs every 1 year or every half a year, depends on the severity, and sometimes they require the ischemia stress test to rule out the ischemic changes. And the CAG or CAT scan or MRI, whatever that's available for you, we do every in a recovery phase, and also 1 year after the onset, and 2 to 5 years, or sometimes every year, we do the follow-ups. It depends on the severity of the vasculature changes. And usually the patient with regression in aneurysms, the drug can be stopped, but aspirin or statins were kept if it seems necessary. But if the patient remaining aneurysms, aspirin plus warfarin or antiplatelet therapy is usually required. Especially aspirin is essential to keep the patient on aspirin for a longer time. And sometimes they need ACEI, ARBs, or statins because of the higher cholesterol level or high blood pressure, or easy to develop the heart failures. In those cases, we add ACEI and ARBs. But remember that the patient, the female patient, the youngers, the ACEI and ARBs are contraindication for those who wants to have the pregnancy, to have babies. So please consult with the patient and get the informed consent. They are on ACEI or ARBs if they want to be pregnant. Okay? And if the patient has the coronary stenosis, the story is totally different. The aspirin plus warfarin and antiplatelet therapy is usually required, and we add ACEI, ARBs, statins, and also most of the cases they require the vasodilators such as calcium channel blockers or nitrates, and also they require the PCI or CABG. And if patient has ischemia, the CABG or PCI is definitely requires, and it's good indications. And also we follow up by CT or MRI or repeated CAGs to see if the stent or CABG is persistent or any other formation of the multiple aneurysms. So it depends on the patient's symptoms and also the ultrasound findings. So this is the summary of how the cardiologist should follow up the Kawasaki diseases all over the world. So I hope in near future the pathophysiology of the Kawasaki diseases will clarified, and the clinical trial that was positive for prevention of cardiovascular complication of Kawasaki disease will come out, and then we can save the life of the youth who are unfortunately diagnosed as Kawasaki diseases. Thank you very much for your attention, and I would like to thank all the faculties and students and the staffs of these meetings and also during my stay. They all support me and interpret my English into Russian or Kazakh to help you understand precisely what I'm going to say and I want to say. And especially I would like to extend my great thanks to Dr. Ahmed-san, my long-lasting friends, and also a very nice person, and treat me as a guest. And I really thanks to him for all the arrangement he did. And also I would like to accept a lot of students from Kazakh for further discussions, and also to further collaborations to enhance medical sciences, and not only clinical but also basic researches. I would like to accept a lot of brilliant students from Kazakh. If they want to study in Japan, please let me know. Please write to me, and then we can have the collaborations. Thank you very much.